Next, continue with the weak diuretics. Weak diuretics. This I already explained. Weak diuretics. These are the weak diuretics. We have carbonic anhydrase inhibitor like acetazolamide, potassium sparing diuretic. This aldosterone antagonist and osmotic diuretic. We have mannitol. So first we'll go with the osmotic diuretics. See here, they'll enter into the renal tubules by osmosis. They have explained here. They are hydrophilic compound that are easily filtered through the glomerulus with little reabsorption that increase urinary output via osmosis. What is osmosis? Movement of fluid from higher concentration to the lower concentration. With that mechanism, and their molecular weight is small, so they easily get filtered through the glomerulus. Okay, they don't need any like thiazide cellulose diuretics. They need a organic acid. Like they used to compete with that and they'll increase uric acid level. That mechanisms are not required to enter into the glomerulus here. Not reach the site of action. Pharmacokinetics, they are given parenteral, mainly IV route. They will give indication to decrease intracranial pressure in neurological condition, to decrease intraocular pressure in acute glaucoma, to maintain high urine flow in acute renal failure due to shock, drug toxicity and trauma. Adverse effects, extracellular water expansion, because by osmosis they will draw the water also. That's why hyper or hyponatremia, like sodium level may increase or decrease, it depends on the condition. Contraindication of acute left ventricular failure, pulmonary edema, cerebral hemorrhage and congestive heart failure. Only in these conditions you can give, but you should not give in case of heart failure also. Coming to the next class of drug, that is carbonic anhydrase inhibitors. Acetazolamide is given orally, darzolutamide, ocular route, brinzolamide. So these two drugs are mainly used in glaucoma. Coming to the mechanism of action, they inhibit reabsorption of sodium, bicarbonate and potassium also. It's not given here. So I'll come to the mechanism. Water and carbon dioxide, they combine and form carbonic acid with the enzyme carbonic anhydrase. When carbonic acid is formed, it splits to bicarbonate and hydrogen. This hydrogen, when it goes out, sodium hydrogen antipotent, that is the mechanism. Anti means opposite, right? One goes out means the other will enter. So hydrogen goes out means, hydrogen goes out means sodium enter. Okay, hydrogen goes out means sodium will enter. When this hydrogen from the blood it enters to lumen, it combines with another bicarbonate molecule and form again carbonic acid, and with the help of carbonic anhydrase they split into water and carbon dioxide. Like that the process will continue. See, while entering sodium into the blood, it takes potassium also. It's not shown here. Okay, so which are the ions will get reabsorbed? One is bicarbonate, sodium and potassium. These three ions will get reabsorbed. So when you give acetazolamide, it's a carbonic anhydrase enzyme inhibitor. As the name says, they eliminate the enzyme carbonic anhydrase. So this enzyme is inhibited, means water and this one carbon dioxide when combined, they don't form carbonic acid here. And like when this step also, like carbonic acid is there, it won't allow to split to water and carbon dioxide. Those steps are inhibited, so there is no reabsorption of bicarbonate, and when it is not split to hydrogen will not go out, so there is no sodium reabsorption also. But these drugs, they increase the potassium excretion, that they can't inhibit, And inhibition of bicarbonate reabsorption, like acid level will be high, so that causes metabolic acidosis. Okay. Clinical uses in glaucoma, they are used. The ciliary process, usually it will absorb bicarbonate from the blood. Increased bicarbonate means in turn it increases aqueous humor. So they prevent absorption of bicarbonate. That's why they are used in glaucoma. In glaucoma, one is you should increase aqueous humor drainage or increase the formation of aqueous humor. Right. One, you should increase the drainage, or one, you should inhibit the formation of aqueous humor. Okay. Urinary alkalization, to increase renal like if the drug is acidic, you should alkalize the urine. If the drug is basic, you should acidify the urine. Acidification, usually they will not do clinically. Okay. Cysteine and uric acid. In metabolic alkalosis, epilepsy also you can use, because acidosis results in decreased seizures. Acute mountain sickness, when they climb hills and all, they'll get a headache, nausea. Those symptoms will be relieved as a symptomatic treatment. Adverse drug reactions, acidosis, hypokalemia, drowsiness, paresthesia, numbness, fatigue, and all those. Okay. To treat this glaucoma, we are using these beta blockers like darzolutamide, brinzolamide. They are mixed with the beta blockers. These osmotic diuretics, usually they will mix with the beta blockers to treat glaucoma as a eye drops. Drugs that inhibit transport in the cortical collecting tubule, that is potassium sparing diuretics we are talking. We have aldosterone antagonist. What is the action of aldosterone means? Aldosterone usually increase sodium reabsorption. To compensate that, potassium and hydrogen start getting excreted. But here, potassium sparing diuretic and aldosterone antagonist, what they will do? They will do opposite work. They increase sodium reabsorption and inhibit potassium or hydrogen excretion. Reabsorption will take place. Sodium will not get reabsorbed. Potassium hydrogen will reabsorb. Sodium it start get excreted through the urine. Direct antagonist of corticosteroid mineralocorticoid receptor, that is aldosterone antagonist. Spironolactone. Indirect inhibition of sodium influx in the luminal membrane. We have amiloride trimethoprim. Spironolactone may get from a question. Synthetic steroid. It acts as a competitive antagonist of aldosterone with a slow onset of action. Mechanism of action: aldosterone causes increase potassium and hydrogen secretion, decrease and also increase sodium reabsorption. The action of spironolactone is opposite. Sodium will get excreted, hydrogen and potassium will get reabsorbed. Side effects: hyperkalemia, because potassium will get absorbed. Anti-androgenic effect, because aldosterone antagonist spironolactone is a hormone, right? So that's why it causes gynecomastia, like secretion of milk from the male breast and breast enlargement, impotence also. Trimethoprim causes kidney stones. Diuretic combination preparation, like we have this trimethoprim plus hydrochlorothiazide. These are things. Hydrochlorothiazide to decrease hypertension, and potassium sparing diuretics to overcome the hypokalemic effect of hydrochlorothiazides. Contraindication: using of ACE inhibitors should not be combined with these drugs. See, like when you give thiazide diuretics, these are the first line drugs. You will combine with the potassium sparing diuretics, because thiazide diuretic it causes hypokalemia, potassium level it will decrease. When you give potassium sparing diuretic, they will increase the potassium level. That's it.